impact successful interactions. Also socially, varying from being socially avoidant to being extremely sociable, but again, not understanding boundaries and such. And then the restricted repetitive patterns of behaviors that we call RRPs. And these are extremely consuming sometimes and very difficult to interrupt when someone is consumed with them. So some of the those core deficits contribute to one's difficulty in communicating thoughts and feelings and being understood. There are difficulties, and affect is tremendously affected when repetitive behaviors are being interrupted and one is being asked to give that up in favor of a non-preferred activity. And also exposure to sensory experiences that can be extremely disruptive as well and overwhelming for the individual, and also prior social experiences that could have been negative. All of this can contribute to one's affect with someone on the autism spectrum. Associated mental health conditions are also extremely important to understand. Anxiety is a very huge contributor to irritable mood and affect, especially because anxiety is pretty realistic in ASD. Individuals do experience these negative social interactions and then become avoidant of social interactions. And so that in itself, and also anxiety that can be compounded when one is introduced to change, all of this can impact mood. Non-compliant behavior is another very important factor as well, because when one gets very caught up with those restricted interests and repetitive behaviors, giving that up in favor of some other activities can also produce non-compliant behavior. And together, anxiety and non-compliant behavior can contribute to negative affect as well. So the best analogy to understand the causative factors producing negative affect, such as irritability or anger, is to use the analogy of an iceberg. So what we see at the tip of the iceberg is those negative behaviors, the negative affect, the tantrums, aggression, non-compliance, and so on. But to clearly understand and treat behaviorally these symptoms, we need to understand what's going on and what's contributing to what we see on the tip of that iceberg. And some of those are those core challenges that we talked about earlier, but also the comorbid psychiatric factors that we talked about, such as anxiety and non-compliance. So it is very, very critical to talk about this, understand this. And the reason being, it is critical to identify these problems very early on and treat them. Otherwise, it can be very impairing, further impairing for the individual who is experiencing this negative affect, because it interferes with further options with education, moving forward with therapies, outings, recreational activities, a lot of stress on the family, siblings, and greatly so also injury, risk of injury to self, injury to others, and property damage as well. So assessing irritability in autism spectrum disorder is also important. We want to know where, how much irritability is experienced, and we want to see how this index changes with intervention. The two measures that are widely used is the Aberrant Behavior Checklist, or the ABC. There is a 15-item irritability scale on the ABC that is used frequently. I have used this to measure progress in interventions, and it captures a wide range of behavioral manifestations of irritability and anger. But again, it also has its disadvantage. It may not capture the total affective element of irritability in the wider spectrum. And another very important measure is the Affective Reactivity Index, or the ARI. This instrument is a 7-item instrument and is also used in the general pediatric population, but has also become quite useful to use in the autism population as well. It has very good internal consistency, and typically when it is used, the full range of the scale has been utilized. So switching to some of the evidence-based behavioral interventions that are typically used, parent training and behavior modification is extremely, is very well known and used a lot. It has a lot of good evidence behind it. Cognitive behavioral therapy for anxiety and ASD comes with some modifications and also has a lot of good evidence behind it. Again, with cognitive behavioral therapy, as well as behavioral interventions for irritability with the individual itself, parent training is also an important component. So the treatment is simply not targeted towards the individual as well, but the parent component is also extremely important to be utilized. So the first step in understanding behavior for families and other caregivers is to understand the cause of the behavior. So essentially, we give parents and other caregivers a behavior log to maintain and manage. So we want to understand what happens just before the behavior, which is the antecedent, and that takes into consideration what actually happened before the behavior, and then what happened right after the behavior, the consequence, or the C. So this is very important information, as it gives us actually what all were the triggers and how was that behavior responded to. So it gives us information as to how this behavior is being maintained. And then it also gives very important information about what supports are necessary to prevent these behaviors from happening. So this slide captures pretty much all of the parent training and preventative measures that we support parents with. So first of all, those visual supports. Is there a good structure involved? Is our communication explicit? And is it understandable to the individual? Do we support transitions? Because change can also be a huge factor in the affective element that can be eliminated with just a little bit of care and consideration in providing a preparation for this change. And then choosing battles, which is the most important battle. Are we giving some choices to give the individual on the spectrum some control over the choices that they can make? And then most importantly, other very important developmental considerations that go into healthy makeup overall for the individual to support them. Do they get enough sleep? Are they getting adequate nutrition? And is there a lot of room for positive, loving relationships to develop to decrease some of that irritability? So this slide captures some of the visual supports that are commonly used. We do this first, and then we get this. And we have visual schedules that tell us what needs to be done before that very interesting or highly rewarding event can occur. And so it prepares them for that event, but it also tells them very clearly what needs to be done before they get to that. We see a very structured classroom that clearly points out what is happening, where the environment is very, very structured. So that limits the attentional difficulties that can happen without that support. And so here are some common visual schedules that are used. It is a great tool, as we just talked about. It supports transitions. It improves predictability, tells the individual exactly what is happening when, and also sets some great routines and helps to ground the individual to that routine. And that sort of eliminates change and some things that can go wrong with unexpected factors just popping up. Social narratives are another very common visual that is used, and this is used to deconstruct a complex concept, especially with understanding complex constructs such as reading social norms or understanding what is expected. And so this is an example of a social story, what to do when I'm upset. So first of all, what does upset look like? What does that mean? How to respond in a situation when they are upset, and what could be some of the consequences, and especially the positive consequences when they respond in appropriate ways to that upsetting situation. Teaching these skills are also a big pathway to supporting parents in, again, breaking down that skill into its constituent components. Instructions will involve modeling, use of prompts, verbal prompts, gestural prompts, always modeling that response using role play, clearly explaining what the replacement behaviors should look like. And you can see in this picture on the slide, this child is actually using a visual support to ask for a break rather than have a meltdown, or asking or learning to wait and asking or accepting no. So using visuals to ask for those important factors that prevent a meltdown instead of having a meltdown, communicating appropriately. So the consequences, and this is also important for the parent to respond to in terms of what are some ways to respond to when, after all of the supports have been implemented, what can we do to continue to enable the individual to cope with saying no or not having the immediate wants met, but ensuring that the child is safe, minimizing the attention to that behavioral response, especially if it is negative and involves a tantrum, minimizing attention and clearly not providing access to reinforcers at that time, and possibly having to leave the setting to minimize the attention that they may get from other sources as well. Again, a key concept here is a lot of practice, a lot of repetition, offering opportunities to work on new skills, and again, having developmentally appropriate expectations and setting goals appropriately. And a lot of consistency is expected among caregivers, providers, and others who are involved in the care of the child. And now we're moving to cognitive behavior therapy for anxiety. Again, here, it is a modified form of CBT, or cognitive behavior therapy. We have to take into consideration the modifications are due to the actual core deficits involved in autism spectrum disorder, taking into consideration the social impairments and communication deficits. Some of these anxieties are grounded in reality, and a lot of the avoidance takes place because of the lack of social skills, and also the adaptive skill deficits that sometimes compounds their perceptions of efficiency in being able to carry out activities. We always incorporate the repetitive interests and use them as incentives. And we use a lot of contingency management of these disruptive behaviors. A lot of work goes into making sure that there is generalization of skills from the clinic into other environments, and of course, making use of all the visual components that we talked about. There's less talking and more use of visuals in communicating some of those core elements of CBT, which are quite complex. Now, CBT is typically used in more intellectually intact individuals on the spectrum, so they are able to think about thinking and make sure that that all of these very complex concepts are understood and using visuals to support. So some of the primary ingredients in the CBT modification is helping the individual to understand their own emotions and being able to read emotions and recognize those emotions in others. A lot of cognitive restructuring, again, using a lot of visuals, and then, of course, exposure to the feared activity or the activity that they are trying to avoid the most. With the parent, there's a lot of parent work that has to occur as well simultaneously, helping the parents support the exposures, the real-time exposures, having them provide positive reinforcement and immediate positive reinforcement, using a lot of encouraging communication, supporting the child, such as making statements like, I know this is hard for you, but we know that you can do this. And a lot of work in supporting the parent in not providing a lot of accommodations to avoid the anxiety triggering incident. So here's an example of social anxiety and school refusal. So the fears have been identified, and somehow the fears are related to how the person will feels or perceives other children as responding and reacting to them. And so those feelings are clearly identified. An exposure hierarchy is developed, and from in ascending order, arriving to school a little earlier, starting with very, very low anxiety-provoking items, and then leading on to more high anxiety-provoking incidents, and then supporting the child with a lot of reinforcement. And here we incorporate a lot of those reward systems that are part of their restricted interests, and use those to reinforce their successful exposure at each level. So moving on to individualized behavioral interventions in understanding their own irritability and responses. Again, in individual work, the focus is on the target issue. And again, as we discussed earlier, there's a lot of work that is put into understanding emotions in self and in others. and understanding how their own social communication impairments and interests can sometimes contribute to some of this affect-related issue, but also using that as reward systems, helping the child or the individual understand their anger episode, what their triggers are, and then using a lot of visuals and supports to understand what are some of those relaxation or coping strategies that they can use to cope with some of that irritability. And also a large component of this intervention also includes parent training. So the parent training, again, as we talked earlier, goes into understanding what is contributing to that behavior, what is maintaining that behavior, and how parent responses could be maintaining that behavior. A lot of differential attention, which is really rewarding and positively reinforcing the positive behaviors, clearly indicating what is expected of the individual during those times, using good commands, effective commands, which are direct, which are more specific, which are not loaded with a lot of language, and also incorporating a lot of daily routines so that there is not much change in those routines that can trigger some of these responses. So here are some visuals that you already may be familiar with in understanding emotions. We also use a lot of visuals to help the individual understand that it's not all anger, but that there is a graduated increase in some of these levels, starting from irritability to supposedly more extreme anger, and understanding all of those different areas that and labeling them as different, so that the individual understands that anger is not just sudden, but it is a graduated sort of emotional outburst. And you can see where there is the color coding, and all of this is done with the actual person involved in identifying what makes them calm, what puts them in that green zone or the blue zone, and then what puts them in that red zone, and what are their responses. Also, along with that, we also help them understand what the accompanying physiological responses would be with regards to being calm versus being irritable or annoyed, and then ultimately ending with extreme anger. So again, here is a visual that clearly explains the anger cycle. First, there is a triggering event, which leads to some negative thinking. An emotional response is triggered, accompanied by some physiological symptoms, and then leads to the action, which could be either positive or negative, depending on that cycle. And here is another visual that identifies the triggers in ascending order. Not every trigger produces the same emotional response. Every trigger could be different, and helping the individual understand that. And then some coping and calming thoughts, from those that may produce a negative consequence to those that may produce a more calming response, helping them identify that, thinking through what will produce a more socially appropriate response, and filling them out in those thought bubbles. From the parent perspective, always looking for the positive, catching the child being good and rewarding immediately, spending a lot of time having positive interactions versus negative interactions, and then exposing them and educating them on the range of reward systems that can be used, that can range from verbal praise to sticker charts and token economies. And to summarize, meta-analysis shows small to medium effect sizes for a good response to CBT for anxiety in autism, and then CBT for symptoms for behavior problems, again, small to moderate effect sizes, and then parent training has clear evidence, especially when the child is young, 12 and under. It clearly improves parent stress. It improves adaptive behaviors in the child, and clearly improves parent-child relationships. And with that, Dr. Barbosa will talk about psychopharmacology in ASD.
Okay. Well, let me share my screen, and then I hope you can all see. It's an absolute pleasure for me to be here. And let me see if I can. Is that it? Oh my goodness. Thank you for your patience. As I said, I'm not very technological savvy. I appreciate so much the patience with all this. Okay. So you can see my slides correctly right now, right? Everybody?
Yes.
Yes. Okay. Thank you. So I am delighted to be here. So I am a child and adolescent psychiatrist, Virginia Barbosa at Norton Children's Autism Center. I am from Brazil and came to ULaVell for adult residency and to University of Michigan for my child and adolescent fellowship. I am thrilled to be talking about irritability and aggression. I really apologize for my, I'll say, difficult beginning. But I hope I can help navigate some ideas in terms of treating aggression and irritability in kids with ASD, because it's an important topic. So some of the learning objectives, we will basically have an overview of how the evidence has been for treating irritability and aggression in kids with ASD. We will talk about the evaluation and potential causes of irritability in ASD, and we will, I would say, again, talk a little bit about the pharmacotherapy and provide a short review of some of the psychotropics that we use to treat irritability and aggression. It's a different perspective from what Dr. Kuravako was discussing, because these are, I would say, situations that require a different type of intervention when we are addressing a child with ASD. I have no disclosures, and I will be talking about off-label medications. So some of the, I would say, difficulties with ASD is that we have a severe and highly heterogeneous condition. So complex with multiple medical comorbidities and multiple psychiatric comorbidities. And irritability is one of the most common manifestations in situations that we are dealing with kids with ASD. The various databases will indicate that over 80% of youth with ASD is affected by moments of irritability or persistent irritability. Overall, it's responsible for frequent ER visits. So kids that have irritability, aggression, self-aggression are 9 times more likely to be visiting emergency rooms and 12 times more likely to be admitted to a hospital. So we're dealing with situations that can be highly problematic, and I hope I can give you some ideas in terms of navigating these difficulties. When we are talking about emotional dysregulation and irritability, what exactly we mean? So we are talking about the tendency to exhibit uncontrolled anger and aggression. So irritability will be more of that excitatory ability of the individual to respond to minor stressors with severe outbursts. And when we are talking about the emotional dysregulation, it's mostly related to the inability to modify an emotional state to promote, I would say, a response that it's more adaptive. Typically is correlated to the lack of capacity to activate processes that involve adequate coping skills. So in terms of a minor stimuli. Common factors associated to irritability in kids with ASD, Dr. Kuravako already mentioned a lot of them, but I'm just going to emphasize some aspects related to the difficulty with communication, difficulty understanding social interactions and relationships, and difficulties with emotional reciprocity as well. So a lot of times the kids will struggle with voicing and expressing their needs. They will become easily frustrated if they are not understood, and that will lead to a lot of a cascade of events. So they will have impaired relationships, they will have peer conflict, they will have, I would say, difficulties managing their coping skills. Three important aspects. So one is the role of sensory overstimulation in terms of becoming a trigger for irritability, and other medical comorbidities and frequent psychiatric comorbidities. So these three aspects are highly, I'd say, relevant when we are talking about irritability, aggression, and self-aggression in youth with ASD. So how does irritability look like? So Dr. Kuravako already mentioned the ABC checklist. So for most clinical trials, the ABC irritability subscale is what is used to measure the response to I would say, tropics in terms of the treatment for irritability. And this is the list of essentially like step by step of what is included in the ABC I subscale. So screaming and frequent mood changes, temper tantrums, aggressive behaviors, difficulties with crying, stomping, demanding things immediately. And it's important to remember that this is again a spectrum, right? And then these kids will have significant difficulty to modify these symptoms. So they react this way because that's how they know how to react. So it's not intentional, it's not on purpose. And another important fact is that these aspects related to emotional dysregulation not always are equal to bipolar disorder, right? So these abrupt shifts in mood are not in aggression and irritability. For a long time, they were, I'd say, attributed to potential bipolar illness, but they are not related to that. So who is more at risk for agitation and irritability? So kids with severe ASD symptomatology, kids with severe intellectual disability, kids that have lower adaptive functioning skills, and frequently kids that have severe psychiatric comorbidities. So anxiety disorders, ADHD, ODD, DMDD, all these frequent letters that we hear all the time. So when we talk about aggression, I've already gave some data related to irritability and agitation, 30%, severe temper tantrums, meltdowns, up to 80%. So the studies vary on the data. Self-injurious behavior, 16%, but other studies have shown a higher level of self-aggression as well, property destruction. And to quantify, frequently we use the CBCL, and we also use the modified over aggression rating scale, which can be, you can download from the web, and it gives an idea in terms of severity of what you're dealing with in terms of agitation and aggression. So it's a good way to measure your outcomes when you decide to engage in pharmacotherapy. A little pause in terms of self-injurious behavior. So SIB in the ASD tends to be stereotyped, different from the habitual SIB that we see in other psychiatric conditions. It's highly repetitive, highly stressful for the parents, and can occur like multiple times in a minute. we can, we typically have a prevalence of around like 50%, and these self-injurious behaviors can lead to severe injury. So you can have detached retina, you can have blindness, you can have mutilation related to that. In terms of the target symptoms for the pharmacotherapy, we know that the core symptoms are not necessarily our goal. So our goal is to actually modify these. This is very, I'm sorry for a moment. So the core symptoms, they're not necessarily a target for the pharmacotherapy. But then we have a long list of potential symptoms that can be modified by the pharmacotherapy. One important idea is that there's always challenges related to the treatment. Frequently, kids are not able to talk about the side effects. They are not necessarily able to talk about their symptoms. The clinical presentation can be atypical. And a lot of times, these kids are highly susceptible to side effects. So you have to be very careful with your decision, and you have to be very careful and have the parents highly involved in terms of the treatment that you're going to provide. So when we are evaluating a child due to irritability and aggression in the clinic, these are some tips to use. Typically, to conduct a brief medical assessment and to optimize the arrangement of the room can be very helpful. It's helpful if you know in advance that the child is aggressive or has a history of aggression, because you can prepare for that to receive that child. It's always helpful to have at least 2 family members to accompany the kid, and also to bring favorite toys and snacks. We always have those available at the clinic to try to minimize the stress. Having in mind that visits to medical providers, they tend to be extremely stressful for the kids. So the office environment is highly overstimulating. Kids typically have difficulties with transition. So you have multiple providers and they go from one, I would say one location to the other. They go to check the blood pressure in one place, go to the office, multiple people involved in the care, and that can be highly stressful. So we always have to have in mind that when we receive a child with ASD in the clinic, even if they are intellectually intact, it's always a highly stressful situation. And we have to do everything that we can to try to minimize that impact. Reduce the wait time if possible. Always helpful to assess the ability of the kid to follow directives and their cognitive level. And as much as possible, minimize sensory overstimulation. Lighting should be lower, noise levels should be reduced, pagers silenced, and number of staff members kept to a minimum. And always they try to move slowly, be, I would say, mindful of your posture, of your gestures. If you're going to be in contact with a child, explain what you're going to do, avoid physical contact as much as you can. Of course, you will have to do the physical assessment, but it's always important to be mindful that sometimes even dimming the lights or lowering your tone of voice can be highly impactful, and you can see immediate changes. Observe other aspects of the child's behavior, so hyperactivity, anxiety, expressions of fear, and the parent-child interaction too. And always helpful to obtain information from multiple sources. So again, when we are evaluating irritability and aggression, it's always helpful to understand what is the quality and the change in baseline functioning that we are dealing with. how many times a day, how long, how excessive, how impactful these episodes of irritability and anger are in the child's life. So if there's a safety concern, if there is a difficulty participating and getting involved with peers, if there's acceptance from the family. So we have to think about these symptoms as highly stressful for the parents and for the child. And if they are not managed, then they can just generate trauma as well. So this is a good, I would say, an algorithm for evaluating irritability. So it was published in 2016, but it's still valid and still highly used. So we assess for safety, and I'm on the second, I'll say, box. You review the patient's history and the level of functioning before before these severe behaviors have emerged. You evaluate in what you're going to prioritize in that situation. So what will be your priority in terms of what you're going to address, and consider all potential contributors associated to irritability, right? So address any potential medical conditions that are co-occurring and can be highly, I would say, interfering. Assess the ability to communicate, and always think about referrals to speech and language therapy, and consider use of evaluations for speech device or communication enhancement strategies. Evaluate potential stressors, and that there is a long list, including the adverse childhood events, right, like abuse, neglect, changes in caregiving, divorce. So all these stressors can lead to, I would say, significant changes in potential irritability. Evaluate adaptive reinforcers. And in those situations, have in mind that the functional behavior analysis that Dr. Kuravako was mentioning is highly important. So especially if this is happening in settings that can lead to, I would say, more problems. So if you're evaluating the child for problems at school, problems at home, having the functional behavioral assessment is highly, it's essential. And then, of course, last but not least, co-occurring psychiatric conditions. Consider the pharmacotherapy if for irritability, if the other resources are not available, or if they are not reaching the goal that we would like. And then, of course, develop a treatment plan and a safety plan in those situations. So there is no algorithm for the treatment of aggression, irritability, and self-aggression to this date, because it's a complex illness. It's complex, multiple psychiatric conditions, multiple, I would say, medical comorbidities, and that limits the ability to actually develop an algorithm. And the treatment is highly individualized. Common medical conditions associated to ASD that can lead to irritability and aggression: seizures, of course, to peaks, early childhood and adolescence. Gastrointestinal complaints, we cannot talk enough about that, right? So constipation, encopresis, they're frequent triggers. And sometimes, because the kids have already difficulty with like regular bowel movements, these symptoms are minimized by the parents. So the parents think that this is how they are, and do not, sometimes it's significant enough that the parents are concerned, but sometimes they just think that this is how they are and it's not causing any major impact. However, you can see a big difference after cleanouts and after the intestinal, I would say, habit is restored. Dental cavities and oral abscesses, so they're frequently overlooked and also highly correlated to irritability. Allergies, otitis, headaches, insomnia. So these are just some of the most frequent common medical comorbidities that are associated to irritability and aggression. So just changing gears a little bit about medications. We typically don't recommend medications for just grumpiness. So the irritability needs to be to a point that is causing risks and significant clinical impairment. So in those situations, we frequently think about pharmacotherapy in combination with other, I would say, approaches. Especially because it can be life transforming for the kid and for the parents as well. We have essentially just two medications that have been approved by the FDA for the treatment of irritability, aggression, and self-aggression. Risperidone and aripiprazole are the ones with the highest level of evidence. Risperidone was approved in 2006 for kids 5 to 16. Aripiprazole was approved 3 years later for kids that are 6 to 17. And they're highly effective, but they have significant long-term side effects. And clinical experience has shown that once the kids are, I would say, when they initiate pharmacotherapy with certain antipsychotics, typically they continue. If they respond to the medication, typically they continue on the medication for many years. So it's important to have in mind that there's a lot to monitor for these kids. The RUP study was the largest well-designed study to evaluate the risperidone use in kids with ASD. It's the research units for psychiatric psychopharmacology and a multi-center, really well-designed study. 101 subjects, diagnosis of autism, significant irritability with ABCI higher than 18, 2 8 weeks, double-blind, placebo control. Mean age of use was mean age of the subjects was around 8 years old, and then the mean dose of risperidone was 1.8. So having in mind that when we start the medication, we typically have a goal for the treatment. We don't just start with a low dose and stay there. We have to keep monitoring periodically to see what is the main goal, what is the max benefit we can obtain with that medication before we jump to a different alternative. This is just a summary of the study. So response criteria was higher than 25 improvement on ABCI or much improved, very much improved on CGI, and risperidone clinically, they clearly separated from placebo, right? Like 69 versus 12% response. Same data, Abilify is quite similar so in terms of the response rate. Adverse reactions. So one of the big problems with the multiple receptor blockers is the weight gain. And you probably all have seen that. Risperidone, average of 3 kilograms, Abilify around the same level. Clinically, we know that risperidone tends to cause the weight gain more abruptly. Abilify will cause the weight gain gradually, but it's still at the end, it's equivalent. Increased appetite, fatigue, drowsiness, drooling, dizziness. So these are some of the side effects. And then there's like information and increased interest in metformin in terms of reducing the weight gain, and we will talk a little bit about that in a minute. Olanzapine is another medication that has evidence in terms of controlling irritability, and it has like multiple trials showing improvement, but they are a small sample. So you can see 3-month open label study with 25 patients, a double-blind placebo with 11 kids. So there is evidence, but significant weight gain has been reported. And there's a head-to-head study, olanzapine and haloperidol, that also showed equivalence in both groups. Ziprasidone also has some evidence. Again, the idea is that it's still less significant than the medications that have been FDA approved. There's considered weight neutral, and there's a typo on there, and small changes with QTC and a higher risk of acute dystonic reactions. In terms of some of the risks, the D2 blockage on the like at the basal ganglia can lead to EPS side effects. Acute akathisia is very frequently seen, and the kids are highly susceptible to that. And then, of course, tardive dyskinesia also can help. Can occur in kids that are using multiple receptor blockers. There's low risk for muscarinic side effects, but still present and can aggravate some of the baseline conditions like constipation, risks related to orthostasis and postural hypotension, risks related to H1 receptor blockers, and more importantly, if we're talking about risperidone, hypoprolactinemia. I put a list of the weight gain so we can have a sense that olanzapine and clozapine are the highest ones, and Geodon is actually the medication that it's considered, I'd say, weight neutral. Other alternatives will include haloperidol, and so there's a strong evidence for the use of haloperidol. There are advantages, but the disadvantage is to use haloperidol in young kids with the high potential of causing EPS and tardive dyskinesia and NMS and catatonia as well. So catatonia is much more frequent in this population, and the use of, I'd say, high potency and psychotics can lead to that. In terms of the recommendations for like minimizing weight gain and the risk of metabolic syndrome, the American Diabetes Association recommends the monitoring weight and height and having at baseline, and always advising in terms of healthy diet and regular exercise. And omega-3 has been, I'd say, highly effective, and also with some evidence that can improve irritability directly. Monitoring fasting lipid panel and glucose, and monitoring the presence for movement disorders, and that will be sometimes very difficult to do if we are doing the abnormal involuntary movements scale. And then, of course, with the hyperprolactinemia, always get that at least at baseline. There is some discussion about the regular monitoring of prolactin, but it's important, especially if you're prescribing risperidone, because other medications can be prolactin sparing. So aripiprazole typically increases prolactin, so we don't need to check prolactin for aripiprazole. Metformin, as I said, there are like range of studies showing that can be effective and well tolerated. This is just one of them, and it's, again, off-label medication. We always try to minimize the weight gain with other measures before we try pharmacological treatment, but sometimes it's not possible. And if the medication is highly effective, and if we can, I would say, confirm with the parents that the medication is effective to minimize the risks associated to aggression and irritability, then it's a possibility to use metformin. Mood stabilizers, the evidence is less significant for aggression, and we have certain medications that we have, I would say, small samples and open label studies indicating some benefits. So the Valproex is one of them. Important in terms of evidence is that we have some evidence with carbamazepine, oxcarbazepine, topiramate, and valproic acid, but we don't have evidence on lamotrigine. So we see very frequently lamotrigine being used, but a randomized placebo-controlled trial did not show any separation from placebo. So lamotrigine is not typically the mood stabilizing medication that we use. And lithium in patients that have clear or more symptoms suggestive of mania or hypomania can be beneficial as well. But again, we go into how we monitor that because it has a very narrow therapeutic window. And just to finalize, to end my conversation, and I hope I have not rushed into things, but it's important to always have in mind that that it's a good tool to use if we are concerned. Frequently, we don't have ABA available right away, and the risks of maintaining a child with severe aggression can be tremendous and can be life-threatening sometimes. So we always have to have in mind that there are alternatives. It's a treatment that has to be highly individualized. We always weight the risks and the benefits when we decide to initiate pharmacotherapy, and we always start low and go slow. So regardless of the weight of the child and how old the child is, we typically start with the lowest dose possible, and then we gradually reevaluate the need to adjust, but having in mind that we need to have a target dosage. We always consider safer alternatives first. If eventually we have, I'd say, a child who is highly impulsive, and we think ADHD is I'd say a main motor for that aggression and irritability, it's always helpful to establish the diagnosis and then treat the condition properly. Always change one medication at a time, be patient. Pharmacotherapy takes time. Always reevaluate the challenges of the medication administration, being mindful of the preparations. So we do not, there are certain medications that you cannot open the capsule, and it's very helpful to use preparations like solutions or suspensions, because then you can titrate the dose slowly, having in mind that the kids are highly sensitive to side effects. Monotherapy is preferred if it's that's the ideal situation, and always look for opportunities to reduce the dose or be prescribed once the kid is stabilized. Having evidence of the combined approach with psychotropics and parent training is it's also essential. So with that, I do appreciate your kind attention, and I appreciate your patience with my lack of skills with the computer.
And with that, yes.
Thanks so much, Dr. Barbosa, and I'll let Dr. Caravaco introduce our panel members.
Well, we are so happy to have 3 panel members today, extremely courageous individuals on the autism spectrum who have faced many challenges and have willingly agreed to be on this panel and talk a little bit about their journey with autism. I'm going to briefly introduce the 3 of them that we have here. Zachary Gebhardt is a graduate student. He's specializing in counseling psychology. He hopes to pursue a doctoral program in the field and contribute to further understanding of ASD and interventions, and we're so pleased to have him on this panel. Alexandra Woodard is a senior in high school, and she's very passionate about photography and has a great sense of humor. She uses humor a lot to cope, and she has a very unique approach to understanding her autism and overcoming challenges. And last but not least is Andy Knapp. He graduated with a major in communications and a minor in sports studies. It is his passion to work as a sports writer. He now does this in his spare time, and he has a part-time job in another field. He is one of the most consistent persons I've ever met, and we look forward to hearing from him as well. I'm going to have all 3 of them briefly introduce themselves and talk a little bit about their journey on the autism spectrum. So I'm going to ask Zachary to start us off. Zachary?
Hi, everyone. Can y'all hear me? It's definitely an honor to be here today. I really appreciate what you all are doing. So I wasn't diagnosed with ASD until I was 14. Growing up, a lot of things were difficult. I freaked out easily when certain things happened. When I grew up, a lot of things had to be my way, and it wasn't because my way or the hard way. It was because I didn't know anything else or didn't feel comfortable with anything else. I felt very uncomfortable with things that weren't my normal and weren't something I planned out. And as I got older and went to middle school, things got more difficult because, I kept to myself. but I would ask a lot of questions in class because I wanted to know specific answers. That put me in the spotlight for a lot of people, and then started letting me get picked on. And then I started getting a lot angry and irritable around the house. I went to therapy, and a few years later, I was diagnosed ASD. Since then, I have trained myself to keep eye contact, to smile when other people are smiling, to keep up the appropriate facial expressions. Even though I may not know what they mean or even mean them myself, I know it's appropriate during conversations, and I want to try to maintain that level. And honestly, I appreciate the difference I have in life because I think even though I may lack some part of something in social communication, I know I gained some other things.
Thank you, Zachary. Alexander, can you talk a little bit about your journey on the autism spectrum?
I sure can. Can y'all see me and hear me?
Yes, Alexander.
Okay, great. So I'm Alex Anna, or Alex for short. It's an honor to be able to have this opportunity to speak about my experiences. So my experience with autism, as it's different for everybody, so it's kind of difficult to put through words, but I can give you this example. We're going to imagine a scenario, okay? We're going to imagine that we're traveling to Japan. Now, mind you, Japan is very different from the US in terms of food, religion, norms, culture, and so on. So, the problem here is you may not have the ability to speak Japanese. You barely know anything about the culture or the language. You just know a few phrases and words. Even then, that's not impressive. And this can be very frustrating because you may need something like food, directions to the local train station, but you can't explain that because, again, you can't really speak Japanese. That Japanese person probably can't speak English either, so it's kind of a bit of a barrier right there. So you may need to find ways to communicate that without directly doing it. So like visual aids, cues, maybe pictures, whatever is necessary and possible. But the good news is somebody in there, depending on what city you're in, like I don't know, Tokyo maybe, since they probably have a lot of Americans coming in, a lot of English speakers coming in, they might be able to speak English. They may be able to help you and guide you through the country. And the other cool thing is they can give you tips and tricks on what to do, what not to do, where to stay, where to go, what you should avoid and why. So that's essentially what autism is like for me. It's like going to a foreign country and not exactly knowing what to do, so you just kind of like bounce it out.
Thanks, Alexander. Andy, now let's hear from you, your journey and some of the challenges you have faced along the way.
Okay, so my name is Andy. So I was diagnosed with ASD at age 5, according to my parents at least. I've since made it through both high school and college to be with a desire to be a sports writer as one of my end goals. Now, my things that I have with autism involve I have trouble socializing with other people. Like I'm kind of shy, but I think it's improved in the last few months. So as for the strengths and challenges I face with autism, I would say one of my strengths is my vast sports knowledge. I have like every single major sport, and I also know a lot of stuff about cars. And as for the challenge part, it's kind of what I mentioned earlier, like, trouble socializing. Mental health challenges with ASD that I have are the fact that I'm kind of more susceptible to getting upset or angry, especially if stuff doesn't go my way. Then what I wish the providers knew that could have helped me more was why exactly autism makes it makes me at least just more easily upsettable. And then also if I could understand more of why I had trouble socializing.
Thank you, Andy. We do welcome questions from our audience. We really want to shift the focus to what is it that you would like for providers or health providers here in this audience to know, to have known something more to help you better. And we could start with Zach with that and then go in order, followed by Alex.
Thank you, Dr. Caravacle. One thing I wish providers may know is how hard it was to communicate thoughts and feelings. So, like when they were asked, "How am I?" I mean, I would say good, even though I don't know what good means, or I would just say the answer that I believe they were looking for. That way, I could just carry up and continue on. I didn't want to feel like I was a burden. I think it would be helpful for providers to understand the tension that those with ASD may have when they come to the room to seek services, even from a pediatrician, because it's just hard to communicate, as Alex was saying. I sometimes, well, a lot of times growing up, I see things through, think of it as a telescope lens. I only see one ending. And so when things are being explained to me and I take that telescope off my eye and I see the whole world, it's pretty overwhelming. So to know honestly the feelings and how overwhelming it all is would be, I think, very helpful to begin with for a lot of us.
Alex, from your point of view, what could have helped you more from health providers who you met along the way?
Okay, so yeah, thank you for letting me answer. Anyways, so fortunately, this has never happened to me, and it hopefully never will. But I I feel like I speak for everybody for whenever I say this, but whenever an autistic individual tells you about their medical problems and experiences they're having, please take us seriously because we feel things, see things, and everything way differently than you probably do. So when we describe our problems to you, don't just dismiss it as something that happens on a daily basis. Just don't say, okay, yeah, that's just normal. Don't worry about it. Like, don't dismiss us and say we are being overly sensitive or exaggerating. We are simply trying to tell you what we feel, and we need you to guide us to the resources we need.
Thank you, Alex. There's a question in the chat, and the question is, in a medical setting with other people's routines that you don't know anything about, the fast pace and little time to individualize and expectations that have not been explained to you, providers want to know how they can help reduce your frustration and anger and support you in a medical setting. So this response can come from either you, Alex, or Andy, or Zach, whoever wants to go first.
So do we just go ahead and type the answers to the thing?
Sure, you want to respond to that, Alex?
I'll let Andy go first.
Okay, Andy.
Yeah, what question was I answering?
So Andy, in a fast-paced environment, in a medical setting, providers want to know how they can reduce your frustration and anger and support you better. So for example, when you come into a very, very busy clinic.
Usually have a problem with that.
Mm-hmm.
Although I will say that when I was a lot younger, like when I was in middle school, I used to be a bit more sensitive to big crowds, like just the amount of noise, I guess. But but then 4 years of marching band in high school kind of helped me get over that.
That's great. That's great to hear that. So you had some exposure to crowds and noises along the way, and that sort of helped you deal with some of the noise and confusion in busy medical settings.
Yeah. Of course, I still don't like sudden loud noises because they scare the crap out of me.
What about you, Zach or Alex?
And this is honestly, it's a good question because it happens a lot. So anytime I'm in a medical setting, a lot of times it's usually fast paced. And what providers could do is ask us, expectations, because when things are going so fast paced, I sometimes just want to go with the flow, so I'm not bothering nobody. I want to make sure, okay, I just get in, get out. They already have fast pace. I don't want to bother. I think what would help is honestly to reduce my frustration is to ask my expectations about why I'm there today. Is there any additional information they would like to know? Kind of make it feel more secure environment and assure to me that, hey, it's fast paced, but this is normal. I'm willing to answer any questions, and I actually have the desire to answer your questions. So, is there anything you're expecting, or what? What is the process for you today? Yeah. So explaining each step. What honestly, that question right there, that statement, explaining each step would help, and honestly, not treating it as it's fast paced, because if it's fast paced and it seems like you are trying to make things go fast, and I'm not I don't want to go out of the way to give additional information because I just want to make sure you get everybody in and out.
Thank you for clarifying, Zach. So clearly, make it very clear, make the expectations clear, and ask you for your opinion and and what is going on with you. Make it more very specific to you. Make that communication very clear to you. I know this is supposed to end at 12, so Dr. Williams and others, are there any other questions, or what about the time?
We were planning, Dr. Kurovakal, to just omit the break and just carry through. So if you had an additional question for the panel members, that would be absolutely fine to go ahead with that.
All right. Okay, so I know the three of you have received therapies to address frustration and emotional problems. Some of you talked about anger as being an issue. So I want to hear about what helped you in those settings and what did not help you. So can we start with Andy on that?
So what has been most important for me to learn about autism was kind of, having that presentation that we had earlier, because that had a lot of things that I noticed, like when I saw it, I'm like, yeah, that kind of sounds like me. Like because I have autism. I think one of the fact lines that they mentioned was like 30% of kids with autism have like some uh I don't know about vulnerability or whatever, but like they're easily or irritable, and that's kind of something that I have. What, like I said earlier, if stuff doesn't go my way that I want it to, that's when I start getting irritated.
There's a question. What has been most important for you to learn about autism?
So I just answered that one.
What about Zach or Alex?
I'll go ahead and answer it. So, what has been okay, so this is actually a really good question, as I'm still kind of learning this one, or at least getting used to the idea is, yes, I may be disabled. Yes, I may have some restrictions or limits, but that doesn't mean I cannot reach my full potential. So, growing up, similar to what Zach or Andy have said, well, I think Andy said this, but he was diagnosed at 5 years old, and I was diagnosed at 4. So growing up, I did have a lot of challenges. Everything was kind of different and whatnot, but I really do think I am improving over the past few years, even as of now. So, like for example, I kind of still have trouble making friends, making the first move and all. Uh, yeah, that's kind of difficult for me because social situations, autism and socializing don't kind of don't really mix here, in some cases. But I am part of my school's yearbook committee, so I do sports photography. I take pictures of sporting events, and the nice thing is I don't actually have to go up to anybody and start a conversation. I don't actually have to go up to you and make friends and like befriend you. All I seriously have to do is carry around a $400 camera, take some pictures, and at least one person is gonna come up to me and annoy me, just because they want a picture by themselves or with their friends. Like it'll be like, Alex, can you take a picture of me, my friends? Hey, Alex, can you take a picture of us? Alex. It's really nice because, well, again, like I said, I don't actually have to figure out I don't actually have to read your cues. I don't actually have to read anything. I just have to listen to you annoy me annoy me while in the middle of something. And another nice thing is I can tell whenever you want a picture or not. So I gotta point the camera at a random angle, and then out of the corner of my eye, someone is just doing this. And I automatically know, oh, I gotta take a picture of them. So I take a picture, and those people will hype me up, say my pictures came out really good. And it's like a really good way to start a conversation and make friends. Like, I don't actually have to go up to you and say, hey, can I be your friend? No, I just gotta carry a camera around and it works. So I can communicate through art, which I think is really crazy but amazing at the same time.
Yeah, well, thank you for that insightful response. Alex, while I have you here, can you tell us a little bit about what really helped you in therapy or in the clinic with a medical provider, and what did not help you?
Um, Again, that's also a really great question, but I think what really helped me overall is just having somebody like listen to me and understand what exactly it is I'm trying to say, where I'm trying to go at. Like when I've had sessions with you, it's really helped. Like we could both sit down, figure out something together, talk about our feelings without it feeling like it's a death sentence. Like it's just really nice to have someone like kind of relax and let me, be patient enough for me to let my thoughts come out, and then we can like arrange it and see like what we can do, how can we solve this, how can we go about this.
Was
Thank
there
you
anything that you
so
found?
much. That was fantastic. What a great panel you are. And thank you so much for sharing your insights. It really makes a difference, I think, for us as providers to hear from you personally and to get your tips. So again, many, many thanks to you all, and to Dr. Caravaca and to Dr. Barbosa. It's been extremely helpful for us. So thank you.